Hi, it's Dr. Noel Williams, August 20th, 2020, Optimal Health Associates COVID update. First, before we go into the COVID stuff, happy birthday to my son Noel, who turned 30 yesterday. He's getting to be an old guy like his dad. So anyway, happy birthday, Noel. COVID update, gonna try to stay positive. There is not very much positive news right now. We'll start with the positives I can find. The first is our case numbers have arced down. We were at, I think, about 775 today or something like that. So we've come down a little. Unfortunately, our deaths are picking up. We started the month, I think, well below 600, and now we're at 709. With, I think, 10 or 15 more deaths today. Those numbers are going to continue. There's going to be some inaccuracy in all the numbers now, which we'll talk about in a second. The big news, which is not good news, but all of you need to understand it and be aware of it and grasp the seriousness of it. The ICU bed situation in the greater metropolitan area is that they're almost completely full. I mean, they might be able to squeeze someone in somewhere right now, but the way this is lining up, I can't tell where the thing is. But anyway, well, I look like I'm looking off to the side. So anyway, that's terrible. I mean, we have no ICU beds. So, and the reason things are not that good is because no one's talking about it. There's nothing on the news. The governor's absolutely gone. No one from the state's talking about anything. The new state epidemiologist did have a little post about wearing masks and things, and that's very nice. And I won't crack any jokes about the fact that they're a veterinarian. But the point is, we're in trouble in Oklahoma right now. The hospitals are full, the ICUs are full, people are getting turned away who I think sometimes might need to get admitted. We're seeing people both in my practice and several other practices that you wonder why they didn't get admitted, but it's just the situation we're in, and they can't do anything about it. And the ER doctors and the ER nurses, we need to be very, very, very thankful for them. All the ER staffs, because they're just overwhelmed and they're stressed and they're having to deal with very difficult situations without having the options they need to take care of the patients. And that gets back again to, why aren't there any options to take care of the patients? Why do patients go in and have severe cough, feel horrible, feel like they're extremely ill, and the ER doctor says, well, there's not a lot we can do. You're not sick enough to get admitted, and they just send them home. And sometimes they'll give them a breathing treatment, and then the breathing treatment helps them, but then they won't write them a script for the albuterol inhaler or the Dulera or whatever. And because their hands are tied, because again, we've had no recommendations from, when I'm saying the federal government, this is not the president, this is Anthony Fauci, Dr. Collins, and Dr. Redwine, who have completely abandoned the American people to any kind of supportive care. The goal is to keep people out of the hospital. The goal is to not let them get so sick they even need to go there. And there's not one recommendation still. I mean, there's journal articles that I've read and a lot of doctors have read, and we try to do what we can. But ultimately, do you really want it to come down to me, the gynecologist, for these people that I'm taking care of? And I'm reasonably smart, and I have a lot of friends who offer me help. But perhaps it would be better if the ER doctor, who has done this 10,000 times, said, oh, I'll write for the Dulera, or I'll write for the albuterol, and I'll put you on the antibiotic for the secondary infection. But they just can't, because they're so, and it's not that it's their fault, it's that they have no support to do that. And so then people like myself and other primary care type doctors have to do it, when really it would be nice if there was a plan. But there isn't. So what everyone has to do is, you need to wear your masks, you need to do your hand sanitizer, you need to socially distance, you need to not be in big groups, you need to take your vitamins, you need your zinc, your vitamin D, your multivitamin, and your melatonin. We really think the fish oil matters, especially if you're older now, because of the thromboembolic events. There's been several cases in the state of Oklahoma where people have gone home when they've been doing better, and then they've had very bad events because of thromboembolism. People have thrombotic events even without hospitalization. It's up to 78% of the affected patient group, especially if you're over 50. And so again, fish oil, fish oil, fish oil. If you're super high risk, which I've put a couple posts out, discuss with your doctor if you get COVID. Should you start a baby aspirin, depending on your situation? Those are all things you need to discuss with your physician or nurse practitioner or your PA, because again, they're all fantastic too, and it's just whoever you have that relationship with. So that's why it's a little bit of a bummer, because I mean, we're surging and there's silence. The testing data continues to show that probably 30% on average of people with COVID have false negative tests. A study that was done by the CDC looking at prison populations, so it was either 14 or 16 prisons. They just tested everybody, but they had to check, the prisoners had to check whether they had any cough, cold, congestion or not. And if they would have just done the testing based on any kind of vague cold system, they would have missed, I think it was 93% of the infected COVID patients in the prison systems. So, I mean, it is just running rampant through the prison systems, but it also illustrates there's about 10 to 12 almost asymptomatic people with COVID for every person that has some symptoms. And so again, the positive to that will be the herd immunity thing will pick up. There's a great journal article again, published or pre-printed. It wasn't published yet, but it was published online, showing that it looks like there's going to be some long-term immunity from a COVID infection. And like I've talked about before, there's at least 20 to up to 50% cross immunity from prior coronavirus cold infections. And just a quick review of that. The original corona cold viruses were documented in the 60s. They gave colds, just a cold. There were 4 of them. They were very stable. They circulated around the world, and it was thus and so. Then some massive mutation occurred in 2001 or early 2002, and voila, we got SARS, which was systemic acute respiratory syndrome or something like that. So basically it's ARDS. And that was a very, very deadly disease, but it was contained reasonably well in China. So it did not kill a ton of people. But that was a huge evolutionary leap by one virologist that I've read. It was an 800-year leap in mutational events. Then we had MERS, Middle Eastern Respiratory Syndrome, or whatever the heck it's called, and then in 2010 or 12, and then now we have COVID. So there have been 7 coronaviruses total, and this is just a new version of the SARS virus. But there's cross-reactivity across the original corona, SARS, because we know from China where there was the most SARS is the least COVID. And so I don't know about if the MERS area had any effect, but the relative number of people who got MERS was only in the few thousand, so probably not. But so it looks like there's some cross-reactivity. So that's very important when we're thinking about immunity. And since we're thinking about immunity, let's think about vaccines. And so tomorrow, I'm going to give a talk on vaccines. This is my second attempt at tonight's discussion, and the first one went 21 minutes because I did a deep dive on influenza vaccines, and I thought, that's a little long, so we're going to save that for tomorrow. So tomorrow's going to be a big discussion on, is there meaning to doing the influenza vaccine? I mean, for 30 years I thought there was a reasonable opportunity for benefit, and I always used to quote about 10%, and I don't know why that was stuck in my mind, 9 or 10% actual effectiveness, which wasn't very much, but it was reasonable. That actually was the 2004 data when I was looking back, but I've looked at the data from 2004 to 2020 because it's easy to get the 2004 to 2020. It's a lot harder to get before 2004. It's kind of mysterious, but and there's some gaps along the way too because the CDC hides data, and we're going to be talking a lot about vaccines for influenza. We are also going to briefly talk about all the other vaccines that work really, really, really well. Things like measles, mumps, and rubella, tetanus, the meningococcal vaccine that college kids usually get, all of the HPV that we use in gynecology and now for young men and men too, because it stops all the genital urinary or genital cancers, rectal cancer, anal cancer, and then the head and neck cancers. So there's a lot of really good vaccines, whooping cough, etc. Chickenpox, potentially shingles, but there may be some things we all need to be aware of about the influenza vaccine that I didn't know, and I'm going to be very embarrassed to have to discuss, because you can't know what you don't know, and clearly I may have been misinformed on a lot of the things about the influenza vaccine. So what I'm going to do in preparation for that is I'm going to put a link to a review of about 20 years of journal articles on vaccines and vaccines having to do with influenza. I'm about halfway through the whole article. I'm going to finish it, and then we will post it, and I would encourage everyone to start reading it. I will put a post too showing the average effectiveness of vaccines starting at 2004 through 2020. Really look at that and see if you notice something that's odd with it. The first time I looked at it, I immediately noticed there was a major oddity that made no sense. It was like instant recognition. And so I want to see if any of you all notice it too, and I'll tell you what it is tomorrow. But when you see that post later tonight, just think, do I see something in that data that is obvious? Because it's just going to be the rates of effectiveness. So that's really all we're going to talk about tonight. Kim, anything else?
There were a few questions if you want to do it.
Sure, let's do those.
Okay. What fat do you recommend with vitamin D? Does it matter?
I always say take the vitamin D with your fish oil, or take it with any kind of meal that has fat in it. So, or take it with a little peanut butter, take it with milk. If you have wiggle room on your weight, scoop of ice cream. But anything with fat makes it absorb much better.
Okay. Feelings on the current antibody test? You get asked that.
Oh, the current antibody test, we still don't know. I mean, if I think the biggest issue is if it's negative, is it really negative? I think if it's positive, you probably at the very least have some type of COVID infection or coronavirus. I mean, if you had a positive swab and then end up getting the test and you have antibodies, you have antibodies. I mean, that group I would say is definite. If you've been completely asymptomatic and you don't have any antibodies, chances are you don't have it. If you were symptomatic mildly but didn't ever get swabbed and you have some, you're probably going to have some cross immunity. But the group that we know for sure is, like if I look at the two people in my family, they both were symptomatic, they both had positive swabs. If they get antibodies at the right time and they're positive, I feel very comfortable thinking, no, they've had COVID and they're going to have some pretty good immunity for the next year or two based on that one trial. But it's a very good trial. And again, you have to go with the history of science with the immunity stuff. But I need to get done or I'm going to be going 21 minutes again. Anything else, Kim?
Yeah, there was a longer one. Here's a quick one. What about taking NAC instead of melatonin?
I don't think the NAC data, so that's N-acetylcysteine, which is a super potent anti-inflammatory. I will look and see if it interferes with the cytokine storm. The melatonin looks like it more directly interferes with the cytokine storm. So while I love N-acetylcysteine, our purpose is the cytokine storm and stopping interleukin-1 and interleukin-6 from building up. And I know for sure melatonin does that, but I will look at N-acetylcysteine and see if I can find any data.
Okay.
All right. Thank you and good night.